So we also use temperature-sensitive liposomes, but the drug we use is doxorubicin. And another difference with the previous speaker's talk is that we put the gadolinium contrast agent inside of the liposome and not attached to the bilayer. So I'm sure you're all familiar with the workflow of MR-HIFU. In this case, our patient is a rat. We put him on a clinical MR-HIFU system table, but we use an adapted receiver coil to get better images. We then inject liposomes. We treat the tumor with mild hypothermia, 40 to 42 degrees Celsius. The liposomes will enter the tumor and will release their content. However, what we do not know at this point is whether our treatment has been successful or not. And to find out whether it is, we have put in this gadolinium contrast agent. This contrast agent becomes more efficient once it releases outside of the liposome. So this is how our normal experiment would look like. We first acquire a relaxation rate map. Then we inject the liposomes. The animals get 2 times 15 minutes of hypothermia. And in between and after cool down, we again measure the relaxation rate. On the right side of this slide, you can see some examples from previous studies. And as you can see, some tumors change contrast have a big contrast change, while others do not. Another thing you might appreciate is that we can see that, for example, this tumor has a lobe that actually receives much less contrast, and so probably also received much less drug. So what we eventually would like to achieve is that we can relate the amount of doxorubicin that we find inside these tumors to the change in relaxation rate that we see. Unfortunately, the drug, doxorubicin, is taken up by cells quickly after release from the liposomes, while on the other hand, the gadolinium contrast agent actually clears pretty quickly. So their difference in pharmacokinetics might obscure this relationship. So what we would like to achieve is actually a way to get these relaxation rate maps while we are performing the treatment. But this is also the point where the MRI scanner is busy acquiring thermometry maps. So one way to solve this is by interleaved scanning. So in a normal situation, when you do MR scans, you would first acquire the full first scan, so this can be a relaxation rate map, and then afterwards you would acquire, for example, the temperature maps. So with interleaved scanning, you can actually switch sequences dynamically at different points within the sequence. And this is what we do. So we only acquire 1 K line of our Luke Locker map, which is a relaxation rate map. And afterwards, we acquire 2 perpendicular temperature slices. So this will give the HIFU the feedback it needs to keep the tumor temperature at 42 degrees Celsius. And after 2 minutes of interleaving these 2 sequences, we also have a full relaxation rate map. On the bottom of this slide, you can see the tumor of the rat, which is a subcutaneous tumor. And we place the 2 slides right next to each other, so the temperature map slice and the Luke Locker slice. So I'll walk you through an experiment. Here you have the temperature on the right side, which is the black line at the top, and here at the bottom you see the average relaxation rate of the tumor. First of all, we wanted to know whether the temperature influenced the relaxation rate. Well, it does, but in our case it's really minor. Next, we wanted to see whether if we did not heat the tumor, so here the tumor is still cooling down a little bit, but we do inject the liposomes, whether this would give a large susceptibility effect, and therefore would change anything in the temperature map or in the relaxation rate. So as you can see, there's hardly any relaxation rate increase as long as the liposomes are closed, so as long as the drug is still not released. And then this is actually the most interesting part of our experiment. You can see that dynamically we can see the contrast of the tumor changing while we are heating the tumor to 42 degrees Celsius. So we can actually see the drug being released while we're treating. And here, afterwards, you see that the gadolinium actually washes out, and this is the whole experiment. So we treated 4 animals with HIFU, and we had 4 control animals. This is the information we used to have before we did this study. So we would only have a relaxation rate map before and after cool down. In this case, like I showed in the little movie, you actually have much more information. We see larger relaxation rate changes. And you can also appreciate over here that the relaxation rate doesn't change a lot in the control animals because there is hardly any drug release. And then finally, we linked the amount of doxorubicin we found in the tumors by fluorescence to the relaxation rate change that we see. And although we only have 8 animals so far, we do think that there's a pretty nice correlation so far. So to conclude, relaxation rate maps were successfully interleaved with PRFS thermometry scans. The change in relaxation rate showed release of the gadolinium from the liposomes. We have adequate temperature control still. And the outlook would be to investigate the effect of the release of gadolinium on the temperature maps, because so far we have only looked at unreleased gadolinium, and to model the perfusion and gadolinium and DOX pharmacokinetics together to get maybe a better insight in the amount of drug that we are expecting. So I'd like to thank you for your attention, and I'd like to thank my colleagues for the support on this study.
Time for a quick question. Yes.
Would you expect that gadolinium would interfere with temperature mapping?
Yes,
the released gadolinium?
Well, we do in a certain extent. The amount of gadolinium that we have when we do not release the gadolinium from the liposomes is small, and if you calculate it, it should lead to maybe a temperature change of about 0.5 degree Celsius.
Okay.
But once it releases, what changes that is that there actually might be some accumulation of the gadolinium, and there you might have a temperature change in your temperature map, which you should correct for. So
yeah, but this is after the application of hyperthermia, so it wouldn't.
Well, during.
Oh,
during
yeah.
It would be. So what we intend to do is to repeat this experiment with a water bath and still use this interleaved scanning sequence to see if we can get a better insight on how big this influence would be.
Thank you.
One quick question. So as a step towards translation, how would you foresee this tool being used? So if it's going to optimize the ability to have real-time feedback, is that something that has a surrogate? Can you compare an integrated thermal dose geometrically to the release of GADO and prove that you can predict it in a different way that's more that you can use clinically? Or is it that you suggest that this specific paradigm would be used clinically?
I would suggest a specific paradigm to be used because the thermal dose on its own would probably not give you such a good, how do you call it, prediction, because it all depends also on whether the liposomes got there or not, so how well perfused the tumor is. So I think you do need that, and not only what the temperature is in your tumor.
So no worries about the GADO with chelation or anything?
In another project, we've been looking at another type of contrast agent, which is an iron-based contrast agent, which is still a T1 contrast agent, and it's been using a clinical iron chelator in order to give the contrast. So we actually think that that one might be maybe suitable for translation in the future, because of course with GADO you still have the safety concerns.
Great. Thank you. Cool work. Appreciate it.